All right, that's part B of Chapter 3. And now we're going to talk about only the decrease in intrathoracic pressure portion of that Venn diagram and how that affects the cardiocirculatory system. Again, in the first part, we talked about the middle part, or increased lung volume. So again, this is a review of the Venn diagram that we're going through in this chapter. And so in this portion of the talk, we're just going to talk about how decreases in intrathoracic pressure without a change in lung volume affect the cardiovascular system. And again, this is somewhat of a Mueller maneuver, and I sort of talked about the implication of what a true Mueller maneuver is a prolonged, forced, very aggressive decrease in intrathoracic pressure, which isn't entirely, actually it's not really at all like what's occurring if you are just quietly breathing. When you're quietly breathing, you're decreasing your intrathoracic pressure only on the order of a few centimeters of water. So a Mueller maneuver is, 30, 40 centimeters of water decrease in intrathoracic pressure, and it more represents truly disease states rather than what's occurring in health. But we can use some of this physiology to help clarify what's going on. So I've talked about what the Mueller maneuver is, and that it usually implies a very exaggerated fall in intrathoracic pressure, but by considering only the pressure effects without a change in lung volume, so there's no change in transpulmonary pressure with a Mueller maneuver, so the lung volume does not increase, it'll facilitate more of an understanding of pressure and volume effects later in the chapter, if we can sort of dissect the two out from each other. So again, this is the Campbell analysis lying into the page. This is my way of illustrating this. And this is functional residual capacity, so your intrathoracic pressure, your pleural pressure on the x-axis here, just to orient you. Again, this portion here marks 0, or atmospheric pressure, so all this pressure to the right is above atmosphere, and all this pressure to the left is below atmosphere. And again, pressure you can sort of think of as like temperature. There's really no such thing as negative temperature. It's all relative to absolute 0, and then there's just increases in temperature from there, but we just reference temperature, positive and negative temperature is just referenced to some arbitrary point, which is freezing at least in Celsius. Same thing for pressure. We're humans, and we're very anthropocentric, so we reference everything to ourselves, which for the most part is atmospheric pressure. So pressure at atmosphere becomes 0, and this is below and this is above, but really it's all a continuum of pressure. So intrathoracic pressure tends to be slightly subatmospheric at functional residual capacity in the normal patient. So if you were to perform this decrease in intrathoracic pressure without a change in lung volume, you're going to decrease intrathoracic pressure, so you're going to drop along the x-axis here, but you're not going to have any change in the z-axis here. There's no change in lung volume. Again, a real Mueller maneuver, you drop your intrathoracic pressure way down here or so. But in a normal inspiratory breath, you're just dropping it a few centimeters of water. So if we were to replay this thought experiment and superimpose the Guyton analysis, we've talked about how this x-intercept here kind of tracks changes in intrathoracic pressure. So at the resting state, the cardiac function curve intercepts here. This is the pressure, this is your right atrial pressure that you would measure if you were to put a catheter into the lumen of the right atrium and measure the pressure inside that vessel. And you can see how it's determined by the intersection of venous return and cardiac function. This is the pressure that you measure. But we're really ignorant to this pressure unless you're actively monitoring intrathoracic pressure. Or with a surrogate of pleural pressure, I've never seen anyone do pleural manometry unless you're draining a pleural effusion. You're actually accessing the pleural space to measure pressure there. But sometimes you can, or you could use an esophageal balloon as a surrogate for your intrathoracic or pleural pressure. I've actually never seen it done. But you can see that the stress across the right atrial wall, or the distending pressure of the right atrium, is actually the pressure in the vessel, measured here, your CVP, less the intrathoracic pressure. So it actually tends to be greater than what you're measuring. When you drop intrathoracic pressure, the cardiac function curve shifts leftwards, and you can see what happened is your right atrial pressure that you're measuring with your CVP monitor decreases. It moves in this direction. Your cardiac output tends to increase, and your distending pressure, your transmural pressure of the right atrium, tends to increase, and that's because you're dropping, you're decreasing intrathoracic pressure greater than you're decreasing right atrial pressure. And the reason that right atrial pressure is not dropping to the same extent is because you've got venous return and cardiac function working simultaneously. So as you inspire in, your cardiac function curve shifts leftward, your distending pressure of the right atrium increases, which tends to increase right atrial volume depending on the compliance of the right heart, and that's what happens. That's what I just talked about. The increase in right ventricular preload is the greatest alteration in hemodynamics, typically during inspiration, because of the very small gradient between the mean systemic pressure and the right atrial pressure. And again, this is your mean systemic pressure down here. And you can sort of think of that as the summated pressure. I don't know if that's a word, summated. The summed pressure of all of your venous capacitance beds, which depends on your stressed volume and the compliance of the venous capacitance bed. That kind of creates almost like an elastic recoil for venous return. And that's what's the pressure head that's driving venous return back to the right heart. And your mean systemic pressure is typically in the order of, kind of like 5 to 10-ish, which means that the pressure gradient for all of venous return to your right heart is only 0 to 10 millimeters of mercury. So if you change your intrathoracic pressure by just a few millimeters of mercury, you're actually causing very profound changes in venous return. And what flows from changes in intrathoracic pressure, certainly decrease in intrathoracic pressure and RV preload, is this idea of ventricular, or not idea, this phenomenon, this known phenomenon of ventricular interdependence. This, I think, has been known for maybe a century or more that this occurs. It's been known for quite some time. That the increase in right ventricular preload during inspiration will subsequently increase left ventricular output because the ventricles act in series. So the fluid bolus, quote-unquote bolus, that the RV gets during inspiration that we saw in that previous slide, after a few, it's usually 1, 2, 3 cardiac cycles later, then preloads the left ventricle. But there's also a parallel effect, and that is can be seen with an immediate decrease in left ventricular stroke volume with an increase in right ventricular volume, and that's because of these parallel effects. The ventricles share muscle fibers, the septum and pericardium, so volume chambers in one, a volume change in one chamber will reciprocally affect the contralateral ventricle, and the degree of ventricular interdependence depends upon the volume of the ventricles as well as the relative compliances of the ventricular free walls and the septum. And I forget who published a model on this, and sort of it's this idea of ventricular interdependence and gain between the two, and they model this mathematically, that it's essentially a ratio of the elastances or compliances of the free walls versus the septum. And I'm going to depict that here, that the pressure in the right ventricle will have more of a hemodynamic effect on the left ventricle when the free wall compliances are diminished. So if the free walls are kind of stiff, high elastance, low compliance, then this effect will be augmented. So this discoloration is not an infarction. Well, I guess it kind of could be, but it's just my way of animating stiffening of these free walls. And you can imagine that the pressure across the ventricle, say during RV filling at end-diastole, will be a much greater effect. That if you suddenly increase the volume of the right ventricle, then you'll tend to bow the septum and impair the LV compliance to a greater extent. And conversely, there'll be less hemodynamic effect on the left ventricle when the septal compliance is diminished. So if you sort of think of somebody like with hokum or a big thick septum that doesn't really transmit pressure all that well, then this ventricular interdependence effect will be diminished. And then just to graphically depict that phenomenon, again, this is the Sagawa pressure volume relationship. This is your end-diastolic pressure volume relationship. So as you fill your ventricle to a given volume, you have a given filling pressure. And what's been shown, and there's a number of papers that have shown this, and interestingly enough, this can even occur in fairly mild pulmonary hypertension in the RV. It's a relatively recent article in the last 2 years in the Blue Journal, that volume loading the right ventricle will result in an acute diastolic dysfunction of the left ventricle, which can briefly, not will, I should say, diminish the LV stroke volume. So if you were to suddenly volume load the RV, if this is your left ventricular end-diastolic pressure and volume relationship, you kind of get this acute diastolic dysfunction of the LV. So if you were to fill to the same volume, you'd have a higher pressure. And what really happens is this dynamic change in compliance during RV filling tends to diminish your end-diastolic volume for the left ventricle. And that's what I've just said. So that leads us into a discussion of how does a decrease in intrathoracic pressure affect left ventricular preload. So we're going to go through the same thought experiment and talk about the LV. So if we're going to decrease intrathoracic pressure without changing volume, this is like a mini Mueller, and we're going from pleural pressure in centimeters of water on the x-axis. Again, this is atmospheric, this is subatmospheric, this is above atmospheric pressure. Superimpose the Guyton analysis, and now this is your right atrial pressure, right ventricular cardiac function curve. This would be systemic venous return here. You inspire. As we just saw in that previous slide, you tend to increase the transmural pressure of the right atrium and right ventricle during diastole. This distending pressure suggests an increase in right ventricular volume, and as we just saw, that can impair left ventricular compliance briefly. And so now this becomes a ghost, and now I'm going to superimpose the left ventricular cardiac function curve. The increase in the end-diastolic right ventricular volume that occurs with the drop in intrathoracic pressure can cause a brief decrement in diastolic function. So if this is your LV function curve, and now this becomes pulmonary venous return as opposed to systemic venous return, well, you can very temporarily decrease the left ventricular cardiac function curve down and to the right, and what that would tend to do is it would tend to increase the filling pressure. Again, if this is pulmonary venous return and this is your LV function curve, blowing up there, you would tend to increase the filling pressure of the LV, and you may temporarily or briefly decrease LV output. And again, this tends to occur, this will be mediated by multiple effects that I'll talk about in a later slide on the Mueller maneuver. But this effect of diastolic dysfunction of the LV tends to be very brief, and it tends to occur just in the first few cardiac cycles after the onset of the decrease in intrathoracic pressure. Now let's continue our discussion of how a decrease in intrathoracic pressure affects the cardiocirculatory system by talking about how a decrease in intrathoracic pressure can affect the right ventricular afterload. The effects of intrathoracic pressure on right ventricular afterload are somewhat controversial and difficult to define, and that's because the afterload, which we model using the Laplace law, sort of best applies to the left ventricle because of the geometry of the left ventricle is quite symmetrical and normal. It's kind of this ellipsoid cavity that can follow. It actually kind of follows a modified Laplace equation. The modified equation is much more complicated. Maybe I'll put it in the book or in the written. It's not a book yet, but maybe in the written volume. In the Laplace, measure or estimates tension across the ventricular wall, which during diastole approximates filling, and during systole approximates afterload. And it's this max tension. And this is the Laplace law for a simple sphere, and so this pressure, the transmural pressure, equals twice the wall tension over the radius. So the wall tension, which is, max wall tension during systole, then becomes the transmural pressure of the ventricular wall multiplied by the radius. So either increasing the radius or increasing the transmural wall pressure will increase the tension across the wall and effectively increase your afterload. And therefore, the wall tension that occurs during the max wall tension that occurs during systole is a product of the volume of the ventricle at end-diastole. That is the preload. So you can see preload and afterload are actually kind of intermixed, or intertwined, I should say, as it approximates the radius of curvature and the transmural systolic wall pressure. And the transmural pressure, again, being the pressure within the ventricle less the intrathoracic pressure. So decreased intrathoracic pressure is accompanied by an obligatory increase in RV afterload because of the increase in the right ventricular end-diastolic. Maybe obligatory is a bit of a strong word here, because the decrease in intrathoracic pressure should increase right ventricular volume, but it may not, depending on if you have collapse of the great veins. You actually may not have much of an increase in your RV preload, but to the extent that the RV preload does increase, or the RV volume does increase with a decrease in intrathoracic pressure, an increase in the radius of curvature will increase the tension across the RV wall, and therefore tend to increase your right ventricular afterload. So what are the determinants of right ventricular afterload? Well, there's the transmural wall tension that we talked about. This is the ultimate, but we'll use this to model what right ventricular afterload is. So what does this break down to? Well, this breaks down into the preload, the end-diastolic RV volume, which approximates the radius of curvature. So as you increase the radius of curvature, you'll increase the wall tension, and multiplied by the transmural ventricular systolic pressure. So what determines your transmural ventricular systolic pressure? Well, part of this is your pulmonary arterial input impedance. And so you can think of your impedance as how difficult the pulmonary vascular tree makes it for blood to be ejected into that. And we talked about what this is in Chapter 2, that impedance is a summation of both vascular resistance, which is more the important component to impedance, vascular resistance, which is essentially a function of the total cross-sectional area of the resistance arterioles into which you're ejecting. It's the impedance is that resistance and reactance is inversely proportional to the compliance of the large vessels into which the ventricle is ejecting. Resistance and pulmonary, I just talked about it, resistance and reactance. So again, this is more the resistance and reactance. These are again components of the pulmonary arterial input impedance, and this is really a characteristic of the entirety of the pulmonary vascular tree. So if there's a very high impedance to flow in the pulmonary arterial circuit as a result of increased vascular resistance or vascular reactance, then the pressure when the RV ejects into the pulmonary artery will increase dramatically, and the tension across the RV wall will increase. The question as to whether or not a decrease in intrathoracic pressure increases the afterload is a bit more complicated, because unlike the left ventricle, where the LV and the aorta together during systole are ejecting from the thorax out to the extrathoracic compartments, where there certainly is a change in your intrathoracic pressure to your extrathoracic pressure, ambient pressure, the RV and the pulmonary arteries and the major branches of the pulmonary arteries are all exposed to the same intrathoracic pressure. So the increase in transmural ventricular systolic pressure doesn't really apply to the main proximal pulmonary artery and its branches, because again the RV and the large pulmonary vessels are exposed to the same intrathoracic pressure. That being said, there's evidence to suggest, both in the early 80s and just from a couple of years ago, using echocardiographic parameters of ventricular strain indices, that during a Mueller maneuver there are increases in right ventricular afterload that may not be related just to the increase in RV volume that you see, that the act of actually lowering your intrathoracic pressure may afterload the RV due to effects independent of increases in the radius of curvature. And certainly during a Mueller maneuver, you're not increasing your lung volume, so that removes increases in pulmonary vascular resistance as the cause. So it leaves this idea of increasing your pulmonary vascular reactance during a Mueller maneuver as the RV ejects. So what could be causing that? Well, it's a lot of hand waving, but there is, I think, one paper, I don't know it off the top of my head, that looked at this in, I think, patients with obstructive airways disease, and there's a suggestion, it's kind of a very circular argument, that as you increase your right ventricular volume with a Mueller, you then decrease your left ventricular compliance by ventricular interdependence, and that increase in your left atrial pressure, that's the result of ventricular interdependence, that increase in back pressure is then reflected across the pulmonary vascular bed, and you're therefore increasing the impedance to flow, sort of by the circular argument. But the numbers in that paper seem to imply this. So whether or not that's really changing your vascular reactance it's kind of difficult to explain. But another argument could be made that as you increase or as you decrease your intrathoracic pressure, you could be dilating the proximal pulmonary artery and the large pulmonary arteries, and that the increase in the radius of those vessels, as you increase the radius of these vessels, you tend to decrease the compliance of a vessel, and that may actually be increasing their reactance. But again, this is admittedly a whole lot of hand waving. I hope that made sense. I was kind of rambling. So what have I said here? A decrease in intrathoracic pressure without an increase in lung volume is felt to increase, I probably already just talked about all this. Without an increase in lung volume is felt to increase the RV afterload because of the increase in RV end-diastolic volume. And as I mentioned, potentially a reflection of LV end-diastolic pressure across the pulmonary vascular bed. And that's, again, by ventricular interdependence. That is, you increase the volume of the RV, you then impair the compliance of the LV, and that raises the LV end-diastolic, the LV filling pressure, and that's really the pressure against which the RV is ultimately ejecting via the pulmonary vasculature. The decrease in intrathoracic pressure per se is not felt to change the transmural pressure, as I mumbled on about quite a bit on the last slide, between the pulmonary artery and the right ventricle, though, as I mentioned, there's some evidence to suggest that this does occur. But if you increase your lung volume, which again doesn't occur during a Mueller maneuver, increase in lung volume does tend to increase the pulmonary vascular resistance, which increases the intravascular pressure and therefore RV wall tension. So a decrease in intrathoracic pressure, again, just moving along the x-axis here, just decreasing pleural pressure in centimeters of water on the x, no change in lung volume on the y. Superimpose the Guyton analysis. The decrease in intrathoracic pressure tends to increase the transmural pressure of the right atrium and right ventricle, which in and of itself would tend to increase your right ventricular afterload simply by a modified law of Laplace. So a small increase in afterload during a decrease in intrathoracic pressure will increase the right atrial pressure slightly, though typically in a clinically insignificant manner in health. So this change in cardiac function curve represents the small increase in afterload that you get with a decrease in intrathoracic pressure. And this effect would tend to augment ventricular interdependence. Again, minimal in health. More profound in severe states of lung inflation, as we'll talk about in the next chapter. Decrease in intrathoracic pressure has complicated effects on LV preload. As previously discussed, the increase in right ventricular dimension that occurs with a drop in pleural pressure tends to impair LV filling via ventricular interdependence. After a few cardiac cycles, the increase in RV output then reaches the LV and augments its preload. Under states of normal heart rate and respiratory rate, the increase in preload tends to coincide with expiration and increased pleural pressure. The increasing pleural pressure during expiration tends to shrink the RV volume and facilitate LV filling. And then the cyclic changing in intrathoracic pressure tends to kind of mitigate or reverse the stresses imposed upon imposed by respiration. It's not advancing. A little bit more about decreased intrathoracic pressure and the LV. Talked about preload, talked about afterload. A decrease in intrathoracic pressure without an increase in lung volume has certainly been demonstrated in multiple studies to increase the left ventricular afterload, but not in a manner identical to the RV afterload, as we talked about. A drop in intrathoracic pressure changes the transmural pressure across the left ventricle and aorta during systole, because they essentially, during systole, the LV and the aorta become a continuous column of blood. It changes the transmural pressure gradient across the intrathoracic to the extrathoracic compartment. And while inspiration does tend to decrease, but inspiration does tend to decrease the LV radius of curvature as via ventricular interdependence. The increase in LV afterload with a decrease in intrathoracic pressure tends to retard the egress of blood from the LV, but again, with small changes in intrathoracic pressure on the order of centimeters of water, this effect is really minimal with these normal deviations in pleural pressure. Again, the greatest change in hemodynamics during inspiration is the increase in RV preload, as the normal pressure differential between the mean systemic pressure and the right atrial pressure is only a few millimeters of mercury. So in a patient with a normal volume status with small changes in their intrathoracic pressure, there is suggestion that maybe ventricular interdependence, and this is probably why you get a normal pulsus paradoxus with you have a normal, not a normal pulsus paradoxus, but you have a normal drop in your left ventricular output during a normal inspiration, is probably more of a preload effect. That is, as you increase RV volume, you temporarily impair LV output by this ventricular interdependence effect. It's less of an afterload effect during normal inspiration. This becomes kind of reversed during very profound decreases in intrathoracic pressure, like you would actually get with a Mueller maneuver. And we'll talk about some of the variability in Mueller maneuver in the next couple of slides. But in a normal volemic patient with a Mueller maneuver, you actually tend to not increase, you don't increase the RV volume as much because you get collapse of the great veins. So the preload effect becomes diminished during a very pronounced drop in intrathoracic pressure, and then the afterload effects then begin to supersede the preload effects for LV output, because as you decrease your intrathoracic pressure to very great degrees, your left ventricular transmural stress goes way up, and that essentially is an increase, or is an increase in your left ventricular afterload. So what are the effects of a decrease in intrathoracic pressure on the LV in terms of its preload and afterload? Well, again, this is the Mueller maneuver. We're only dropping intrathoracic pressure without a change in volume. I'm going to do my little ghost effect again with your RV function curve here. Remember, it tends to decrease your intrathoracic, or it tends to decrease your right atrial pressure, augment your right ventricular output, and increase the distending pressure of the RV. And you can sort of get a sense that this is going to depend on your volume status, so where your venous return curve is. If your venous return curve is way down here, as we'll see in the next slide, versus way out here, your transmural pressure or distending pressure of the RA and the RV will be quite different in different states. But let's say this patient's euvolemic, you tend to have because of the small gradient between systemic venous return in the right atrium, a very small change in intrathoracic pressure results in a fairly pronounced change in venous return. You tend to distend the right atrium and the right ventricle, which then impairs temporarily left ventricular output. So this now becomes a ghost. The increase in end-diastolic right ventricular volume causes a brief decrement in left ventricular diastolic function. So this is now your left ventricular cardiac function curve. This venous return curve is now pulmonary venous return, not systemic venous return. And you tend to get a little decrease in your left ventricular compliance in the first couple of cardiac cycles after a drop in your intrathoracic pressure. In theory, then, there's an increase in left ventricular afterload as you increase the left ventricular and aortic wall stress relative to the extrathoracic compartment. Would tend to decrease the left ventricular function curve down into the right as well. But again, with the decreases in intrathoracic pressure that you have with a normal inspiratory event, this would be a very, very minimal response. This only becomes a very pronounced afterload effect if the intrathoracic pressure is dropping, 20, 30, 40 centimeters of water downwards, which would tend to have a much more pronounced effect on the transmural wall stress. So again, in the normal patient, just to reiterate, more of a diastolic issue in terms of how the change in intrathoracic pressure affects left ventricular filling and output. So we've talked about the Mueller, that is just a decrease in intrathoracic pressure without a change in lung volume. And you may pull up 5 or 10 articles and you actually may get 5 or 10 conflicting results as to how the Mueller maneuver affects right ventricular preload, right ventricular output, and actually left ventricular dimensions, as we just talked about. And so in theory, one would expect both RV preload output to increase, one would expect both right ventricular preload and right ventricular output to increase with a lower intrathoracic pressure, as we just talked about. But as we saw, the right ventricular cardiac function curve shifts leftward along the systemic venous return curve, and this can, if you start getting venous collapse, if you start hitting that portion of the venous return curve where you have maximal venous return, you will actually fail to increase your right ventricular dimensions and therefore your right ventricular preload and output. And this is really dependent, whether or not you start to get great vein collapse is really dependent upon the baseline mean systemic filling pressure of the patient. In other words, volume status, as we talked about in Chapter 2, what your mean systemic filling pressure is, as well as the resistance to venous return and the shape and slope of the right ventricular cardiac function curve. So I want to take you through this kind of a similar thought experiment of multiple mini Muellers, as I'll call them, because again, we're just decreasing your intrathoracic pressure small amounts here, which you would get during a normal inspiratory effort. And a Mueller maneuver is really a big drop in intrathoracic pressure to a profound degree. So again, this is our Mueller, drop in intrathoracic pressure, no change in volume. Superimpose the Guyton analysis. It's going to tend to distend, as we've seen a whole lot already, your right atrium and right ventricle, and increase your cardiac output. And that's a function of increasing venous return to the right heart. We've talked about this already. So let's just continue on with this thought experiment, and let's do this at different at a different volume state. So for argument's sake, let's call this venous return curve, which is now kind of a ghost, we'll call this euvolemia. This patient is now hypervolemic. So we've loaded this patient with a bunch of liters of crystalloid, and now their mean systemic filling pressure is high because they have a high stressed volume, and their venous return curve is shifted rightward. So this patient is now hypervolemic. Well, you can see already at baseline, his transmural filling pressure of the right atrium and right ventricle is already high on as a function of his increased volume status. And now if we were to do the exact same Mueller maneuver, the same decrease in intrathoracic pressure, now look at his distending pressure. So this, in theory, would have a much greater hemodynamic impact immediately on the LV via ventricular interdependence in the hypervolemic patient. Same decrease in intrathoracic pressure, greater increase in the distending pressure. And you can imagine that if you were to increase or lower your intrathoracic pressure to a greater degree with a more forced inspiratory effort, you would tend to augment this distending pressure. So continue the thought experiment now in a hypovolemic patient. So this patient has had gastroenteritis or has had a GI bleed or has been NPO on Lasix. So this patient's venous return curve is now shifted to the left. Well, this patient now at baseline is already having venous collapse. Remember this plateau portion, this maximal venous return, this essentially occurs when the pressure in the great veins entering the thorax drops below its ambient pressure. And in the IVC, which tends to accommodate upwards of 75% of your total venous return, the IVC, this occurs when the IVC pressure drops below your abdominal pressure. So in this patient, if we're to do the same mini Mueller maneuver on them, we'll look at their distending pressure. And now look at their distending pressure hasn't changed. Even though their intrathoracic pressure has dropped, because the veins are collapsing, you're on this, you kind of reached your venous return speed limit, and you can't actually fill the ventricle, the right atrium and the ventricle anymore. So this volume deplete patient for the same Mueller maneuver would actually have a much diminished ventricular interdependence effect, and they wouldn't really augment their cardiac output at all. Look at their cardiac output. It stays here. Oops, sorry. Their cardiac output is here, and then with Mueller, it stays here, and that's because you've reached maximal venous return. So this patient would have minimal parallel effects, that is on the LV, that is a minimal ventricular interdependence effect, and it would have minimal series effects. So a few cardiac cycles later, there really would not be any augmentation of left ventricular preload because your right ventricular preload has not increased. So now let's continue the thought experiment, but in a patient with diminished cardiac function. So what is this diminished cardiac function? This patient has, say, hypoxemia, they've got high RV afterload, they've got some right ventricular ischemia, they've got some tricuspid regurgitation, a valvulopathy, maybe they've got some AFib. Multiple things drop your cardiac function curve down and to the right. The important thing is that you have less of an output for a given filling pressure. So now this patient is going to perform the same mini Mueller, but now I want you to think of this patient, this depressed cardiac function, in terms of a hypoeuvolemic and hypervolemic patient. If you decrease your intrathoracic pressure, for the hypovolemic patient, there actually tends to be a much greater increase in your distending pressure. So this patient that has poor right-sided function, which could be due to a plethora of causes, they tend to have they do have a greater parallel effect, a greater ventricular interdependence effect. The euvolemic patient, it would be even greater, and certainly, as you can imagine, the hypervolemic patient, there would be an even greater distending effect. So you can imagine this being, the let's say this is the cor pulmonale patient who has a decreased right ventricular function curve because of very high RV afterload, because they've got terrible emphysema and they haven't been taking their Lasix, and they've got all this lower extremity and abdominal edema. And they take a deep breath in because they're very short of breath. Again, I'm talking about a sick patient. Well, they're going to have a very large increase in their transmural pressure of the right atrium and right ventricle, which would tend to have much more of a ventricular interdependence effect. But interestingly, they all essentially have the same cardiac output, so they have a diminished series effect. So there'll be less of an increase in preload to the left heart a few cardiac cycles later, and mostly just this interdependence effect. So that's it for a talk on intrathoracic or decrease in intrathoracic pressure and cardiocirculatory function. In the first part we talked about an increase in lung volume. Then in this part we talked about just a decrease in intrathoracic pressure. So the next part we'll obviously put 2 and 2 together, and we'll talk about spontaneous ventilation.